Good morning, good afternoon, and good evening, colleagues. Welcome to the 12th webinar of the Global Prevention Coalition and South-to-South Learning Community of Practice for Key Populations. It's actually a dozen webinars that we've had over the past 4 years, and in a way, there's a circle or a rounding up of this, important 4 years in us coming back to this question of scalable primary prevention programs for key populations, which we covered in the very beginning of this webinar series, but from a very different perspective. At that time, actually, there was planning for scaled programs in the context of Global Fund and scaled trusted access platforms, expanding programs at the time of substantial resources available. At the moment, of course, we're discussing the same topic again, sustainable and scalable prevention programs at the time of a funding crisis. And this angle of actually sustainability is what is new for those of you who have been with us a few years ago and who already know the guidance around scaled key population programs and trusted access platforms, as we have promoted it before. We've had a session in the morning with different country examples. So if you have been part of the morning session, there's still something new in this afternoon session. We have for this session actually a translation available in French, Portuguese, Spanish, and Russian. So please do use the translation and interpretation icon to get to your respective language. Now, we can move to the next slide, which has a brief overview of the agenda. We will first start with a review of the evidence on key population responses, and then move into actually the sustainability roadmap and what it means for key population programs. We then have 3 country examples: Brazil, Nigeria, and Moldova, a community perspective from Mozambique, and then finally, we hope to still have some time for a panel discussion and some questions from the audience. And that brings me to an invitation for you to actually, introduce yourself in the chat and use the Q&A, which is a separate button that you will see for the questions that you may have to the panelists or to the group or overall, or to your peers from other countries. So as mentioned already in the beginning, the topic today is scalable and sustainable programs. And a lot of countries are actually facing at the moment this question. At the time of limited resources, how can we reach all our key populations, maybe not just in a few places through projects, but really wherever key populations live? And that's a question that has been answered differently in different countries. Some countries talk about integration, integrating key population services and public health services. We have models, with relying more on sexual health services as a platform. We have, of course, for a long time had community-led models where social contracting is used at the countrywide level to actually provide services. And these services are actually used in different combinations in different countries. So today's session is really explore what are the examples, what are the patterns from different countries, and what can we take and learn from that. So we want to share evidence. We want to deepen our understanding of the essential components for sustainable programs, both the programmatic and the financing components. Practical examples will be shared, and really we want to identify also any collective actions that we can advance together, or where countries can collaborate or seek support from other countries or global partners. So with that brief introduction, I'll hand over to our first speaker, Hedda Marie Schmidt, with the Global Prevention Coalition Secretariat, co-hosted by UNAIDS, and she also works for WHO as a program advisor, and she will present an analysis of country models for sustained and scaled key population responses. Over to you, Helen Marie.
Thank you, Clement. I'll just wait for my slides up, but in the meantime, I am here to present on scalable and sustainable and successful HIV primary prevention models for people from key populations. And this is the result of an analysis that was undertaken of some key countries or key examples and the findings from that. Next slide, please. So as background, we know that to reach the global AIDS targets will require a substantial acceleration in our HIV response. And this is particularly true for prevention and even more true for key populations. There has been very limited progress overall in reducing new HIV infections, only a 39% reduction since 2010. And as you can clearly see in the aqua on the slide, on the graph to your right, key populations account for more than 50% of new HIV infections, new HIV acquisitions currently. So this is something that I don't think is gaining enough attention and importance. Next slide, please. We know one of the reasons that we're particularly concerned about this now is, one, the epidemiology, but two, we know that a lot of the key barriers, like underfunding, stigma and criminalization, and fragmented services are still very important and haven't been overcome. And of course, the funding cuts have had a profound effect on HIV prevention programs among key populations. They've been some of the most affected since January. But effective models that are sustainable and delivered at scale are essential for that long-term impact and ensuring key populations are not left behind. Next slide. So this analysis, the objective, next slide, please. The analysis was examples of scalable and sustainable HIV prevention service delivery models for people from key populations. And the idea was to really identify important features and lessons that would help the plan. It involved a desk review and a global call for case studies. There were more than 250 informants that were contacted. And the criteria included progress towards sustainability, to scalability, looking at good service quality and coverage, innovation, and it focused on programs for gay and other men who have sex with men, transgender people, sex workers, and people who inject drugs. We didn't include people in closed settings such as prisons in this review because the service delivery and the way that this is funded is quite different. So it's really based on programs for any of those four populations. And there was no country that was, or no program that was delivering something perfect across one or any of these populations. Next slide, please. So there were many countries and examples that were suggested, but we're only able to deep dive into 9 countries. So these countries included Australia, Brazil, El Salvador, Kenya, Moldova, Nigeria, the Philippines, Thailand, and Zimbabwe. So what you will see here isn't the result of an exhaustive canvas across multiple countries, and there were great examples in many other countries, but we had to narrow it down to a few that we could deep dive in. We aimed really to have variation between countries and to look at different regions, country income levels, and types of epidemics and other features. Later on in this webinar, there is a selection of countries presenting their own case studies, so I won't present those here. But I do also just want to quickly emphasize that this review was undertaken prior to the donor funding changes in January of this year. But the overall takeaways are still really relevant, even if the situation, unfortunately, in several countries has changed and indeed become much more difficult for programming for key populations. Next slide, please. So one of the key aspects that we reviewed was how key population programs for primary HIV prevention are funded. And these were divided from the review basically into 3 buckets. These buckets span a continuum from fully or mainly donor funded to those that are fully domestically funded. Most models naturally fell somewhere in between. Model 1 is a mainly donor funded model with small funding with funding going to government, for example, government agencies or CSOs or both, and less frequently to the private sector. Under these sorts of models, donors may often procure on behalf of the countries and or support national procurement. This is a cost-effective strategy in the short term because quite often donors can access cheaper prices or lowest prices given huge volumes for procurement. But it does require in the longer or medium term as countries take ownership of their programs, that transition to domestic procurement and the capacity to do that. One thing to really highlight is that even under a model that is predominantly donor funded, CSOs, and I use this term broadly because in different countries, there are different community-based organizations, community-led organizations, and civil society organizations are termed differently. So just using this as an umbrella term. CSOs play a really important role, being either directly or indirectly donor funded as the majority. And donor funding has also been quite important for pilot program implementation. Under Model 2, there is significant domestic funding contribution in addition to donor funding. And these models are often managed through a semi-autonomous agency, and it looks very different in different countries. But it could include the pre-purchase of bulk services or delivery through contracts or grants, reimbursement to civil society organizations or other organizations or agencies through, for example, national health insurance schemes or social security schemes funded at specific facilities. These can and often do include CSO-led and CSO-supported service delivery. Challenges within these models often include, however, funding for core and overhead staffing costs, particularly for CSOs, as grants may not fully and reimbursement may not fully cover these operational costs. And there can be restrictions, of course, in national health insurance. And under Model 3, there is no external donor funding or very little, and the service is really funded by governments through public facilities, CSOs, and also potentially private services. Next slide, please. Service delivery typologies also bring together some of the main components of the delivery of primary healthcare services. Not every component exists or should exist in every country. So there is a lot of diversity and a lot of opportunity for customization according to the needs and preferences of people from the population and the context within the country. The key message here really is that there are a diversity of HIV primary prevention services that are being delivered for key populations, whether public primary healthcare facilities in the community, they can be KP-friendly primary healthcare facilities, and these often involve co-location with or partnership with CSOs, sexual health services, which are typically government-run, private healthcare services, and increasingly things like pharmacy and online-run services as part of that innovation. And services with CSOs in the lead. For example, community-led organizations running primary healthcare facilities or drop-in centers, mobile and outreach services. And these also community-led services really facilitate entry into these other parts of the system. Barriers can exist to accessing many of these services, particularly ones that are not community-friendly or run by the community. And it's not only stigma and discrimination, but there are many reasons that services may not be acceptable or accessible. And there's a lot of work that still needs to be done to ensure this. One of the key things really is around integration of the services and inclusion, not just integration, but inclusion and the avoidance of siloing. And this can be supported by these sorts of funding models that we discussed earlier that integrate CSO-led services into that broader healthcare system, bringing services as close to people as possible and examining efficient ways to deliver services. But CSOs almost always central across the models that were examined. Next slide, please. So across the various models, there were a number of common features, and these common features are on a continuum. There was no perfect model that exists. I don't know if there can be a perfect model, but we can get close. Domestic financing and national ownership, of course, is critical. Integration into primary healthcare and social insurance was something that was really helped to strengthen the sustainability and the scalability of some of these models. Enabling legal and policy environments, of course, are key. Community-led and person-centered services across the models. And I mentioned this already and emphasized it, but it cannot be said enough that CSOs and community organizations are trusted. They are embedded within communities. They are innovative. Some of the best innovations come from community-led services, but they require adequate funding and support within the framework. And of course, the use of differentiated service delivery is also really important. There are lots of models that exist, and offering just one model is not going to meet the diversity of needs and is not going to be successful in really ending HIV as a public health threat. Co-location and strong linkages of CSOs and public services has really good potential, I think, in a lot of places. Task sharing and peer-led navigation, secondary distribution, and of course, that innovation, particularly using virtual interventions. Next slide, please. And so there is a real need to prioritize that domestic financing for prevention in sustainability funding. To date, Global Fund and PEPFAR have played a really significant role in funding services for key populations, particularly things like staff salary within CSOs. There's a need to establish or strengthen, where it exists, evidence-based mechanisms that have a good propensity for sustainability and scalability. And these could be social contracting, national program or health insurance reimbursement, pool procurement, and things like this. And to institutionalize CSOs and peers within that healthcare system. It is important to engage communities in planning and delivery, undertake the reforms that are needed to enable this, and to invest. Leveraging real-world evidence, of course, this is part of what we're presenting here, and it's a very quick dive into what we saw. But there is real-world evidence that will be presented also later in this webinar that can help your country to inform their investments and the directions, and to advocate towards integration, innovation, inclusion, and scale-up. But there is no one-size-fits-all model. We can't take the model from Australia or Zimbabwe and simply transplant it into another country. We have to be really pragmatic with this. Next slide, please. I realize that I am almost out of time. What I wanted to say here is that there has been a profound change since January 2025 and significant funding cuts. UNAIDS and WHO have been monitoring and responding to the impacts of these funding cuts and service disruptions, including key population services, and most of you have been as well. Next slide, please. So some very quick advice around adapting to these abrupt reductions in donor funding. I've already said how important it is and how much it's been disrupted, and the disruptions particularly for key population-led services and CSO-led services. And of course, this really does jeopardize things like PrEP, harm reduction, care navigation, community-based services, and also the legal and funding and broader system reforms that are needed for key populations. So immediate adaptation is needed through domestic resource mobilization, and many countries are already doing this. Inclusion in things like national health insurance schemes, if that's what your country has, but whatever the scheme is, emergency transition plans to maintain those critical services, greater support for multilateral partners for short-term gaps, advocacy to protect and to prioritize key population services in national budgets. And now more than ever, we must invest in these resilient country-owned services. Next slide. I am 30 seconds away from finishing. There is new guidance from WHO on prioritization, which is featured here, and there will be a link. We will share these slides with you. And next slide. Finally, just a thank you to everybody who contributed to this work, and particularly to Graham Shaw, who led this work on behalf of the Global HIV Prevention Coalition. Thank you very much.
Thank you so much, Heather Marie, for really giving us an overview and a snapshot of this work. We still encourage you to watch out for the report that will come out of this study later this year, which will have all the details on the different models, insurance-based or these semi-autonomous contracting bodies for CSO-delivered responses. So all of that will be documented in a detailed report with all the country examples that this actually is building on. And we're also working on updating this guidance on scale key population responses, known informally as the Trusted Access Platform document, which you can find on our webpage in the 2022 iteration, but it will be updated again this year and also come out later in the year. Without further delay, I'd like now to invite Iris Semini, a senior advisor with the Health Financing and Sustainability team in UNAIDS, to give us an overview on the sustainability roadmap development processes, which are so critical for actually informing some of the transformations to make HIV responses, but in particular also key population responses sustainable. So over to you, Iris.
Thanks, Clemens. Can I have the first slide? Very pleased to be part of the discussion, and I'll be also very pleased to follow up on how the countries are taking these actions forward. I'll share with you today, next slide, some updates on the sustainability roadmaps, which they started before the funding crisis. They started in early 2024, but as the funding interruption and ODA decline in early 2025 occurred, many countries reprioritized the focus on sustainability for optimization, simplification, with the focus now not only on sustainability, but also transition planning. Two key messages in this slide. We are at a new critical moment. The Global AIDS strategy is being developed. New targets are set for 2020-30. So as we think about planning now, we also think about how to sustain the future. So both elements are present. The second message is about the number of people living with HIV will continue to rise. In the absence of the vaccine, HIV and AIDS treatment services will be long needed. So this is not an issue that will be over very soon, actually. That's why we need immediate planning and long-term sustaining impact. And the third message is that the funding discontinued, or the funding pause, has created service disruption, in particular for HIV prevention, community-led services and key population, which has put increased pressure on how we address the derailment created by the funding cuts, right? So the sustainability and transition planning looks at both elements. How do we simplify? Next slide. How do we prioritize the response? But also how do we ensure that we secure financing that builds systems that are people-centered and community-driven. So we all know it's not only about financing, but financing matters as well. The funding before the 2025 crisis was already the funding patterns were already showing us that those who are the programs that are more dependent on international assistance are exactly HIV prevention and key populations. So the discussions around advancing the response in HIV prevention and key population and making sure we build mechanisms that sustain those response beyond funding dependency are a key priority now. Next slide. We developed the primer of HIV sustainability in 2024, where this holistic framework looked at sustainability through political leadership, laws and policies, financing, services and solutions and systems with people at the center, which were all key elements that Heather Marie also highlighted in the models that are working, sustainable and effective for key population. So this new holistic approach to sustainability and transition continues to be even more relevant in this moment of time. Now, where we are is that many countries started the sustainability roadmaps last year, but and you might have heard that it's composed of two parts, but actually there is one sustainability roadmap at the end. So I think this webinar is a good opportunity to call upon on all of you to make sure that you are participating in the sustainability and transition roadmap discussions in countries, in priority decision making, and into the resources that are being requested or allocated. Next one. For those, so there are steps. I'm not going to go through the steps, the slides will be made available, but for what we need to understand is that the first part of the roadmaps looks at country vision, high-level political commitment and outcomes. High-level outcomes are transformations that we want to have in place in order to sustain services, capacities, and secure impact. And then the second part is about taking those political commitment and high-level outcomes into a 2 to 3 year costed operational plan. What needs to be done? What should we engage in ensuring that we achieve the high-level outcomes? Basically, that we reach that level of policy, systems, community capacities, service delivery interventions, and financing in a way that will allow us to advance towards epidemic control and sustaining impact. Next slide. So just to show you that, next one, just to show you that before January, there was a number of countries that had already finalized the first part. Please ignore the reference to Ghana, they're still reviewing it. And another number of countries that had initiated it. On total 30 countries. What is relevant to know about this is that these high-level commitments and high-level outcome expressed in the first part of the roadmap part A, or in those that initiated, remain relevant because during the crisis and for moving forward with the second part, countries are leveraging those commitments in order to define the 2 to 3 year operational plan. So these commitments are relevant for you as entry points to advocate, to turn these commitments into reality, even in the current funding crisis. So just to say that all the roadmaps that we analyzed, 10 of them, have identified the centrality of key population in the response, and they define key populations at the intersection of sustainability and risk, acknowledging the different vulnerabilities. Next one. What we saw in the roadmaps as well is that the challenges are, many of you know, are reflected in the roadmaps as well, which is a true testament to the consultation and the country ownership, heavy reliance on donors, service delivery, coordination, and fragmentation, through parallel systems, donor funding, government funding, lack of quality data in terms of surveillance and monitoring, the element of illegal environment, stigma, discrimination that undermines the effectiveness of services, all of this combined undermine the effectiveness. On the other hand, you're going to see a graph where it shows in red the USG funding to HIV response. So we can imagine that those countries that are so heavily dependent are those that face the severe cuts and interruption on HIV prevention services. Next one. So how do we take this situation and we turn it into opportunity? The roadmaps have, the 10 one that we analyzed, have prioritized social contracting, increased KP representation in decision-making, They have proposed dedicated budget line or government allocation for key population programs. They have proposed or they have committed otherwise to institutionalize CoP programming into planning and budgeting, improve the data into system, and then scale up human rights and stigma reduction initiatives. So if you participate in a country dialogue about developing the roadmap or advancing the Part A to Part B, identify in the document that exist this type of commitment and leverage them, advocate for turning them into reality, because these are documents owned by the countries, right? Not UNAIDS. And then at broader level, we can see some interesting discussions around expanding social protection for key populations and equity-driven financing governance reform. As HIV financing is increasingly integrated into health insurance, into other mechanisms, strategic purchasing of the healthcare financing, it is important that equity and protection of rights and access for key population is not lost in the bigger reforms. Next slide. So our call is that use these elements of roadmap, the dialogue around sustainability to advocate for participating in the changes that are being made. One of the elements that we see that is going to gain prominence is integration, streamlining services into healthcare facilities. So how can it be done in a way that still protects access and equity for key populations? I've also listed a number of high-level outcomes from the roadmaps, which clearly speak to the commitment of the countries to move forward with these suggestions. Now, what is, for example, important to say is that all roadmaps have prioritized social contracting or the public financing of community-led services, including for key population, as their next commitment to the increased sustainable financing. This is an area that doesn't require a lot of resources to operationalize it, might require more to implement it. So putting this in the operational plan is critical. Next slide. So going back to the roadmap, there are the phases, right? So many countries now are either on the phase 3, where they're starting to design the Part A, or they are starting the Part B. So we will encourage that we as UNAIDS can make known through your community of practice and our UNAIDS colleagues which countries are started, where is the dialogue happening and the analysis ongoing, and then to encourage your participation. But the participation, what we have learned so far, is it important that you come not only with strong advocacy, but with strong evidence and ready-made models to propose to the government that they are efficient and effective for integrating in the sustainability roadmaps. Models that work, like Heather Marie was explaining, which I find it extremely useful and relevant for the context, in a way that doesn't fragment further the system, but strengthen the entire systems for health. Next slide. You're going to find in the new guidance that we launched for the second part, we launched it yesterday, the guidance for the second part of the sustainability roadmaps. Some of the key components where you can participate is around data analysis and funding gaps. We faced a lot of challenges working with countries on detailing the funding gap for key population programs and communities. So your input and perspectives are useful. Next one. And the next critical entry point can be the development of the 2 to 3 year costed transition plan. In the guidance, you'll find some key questions to guide the country reflections. Thanks to Clemens and the team that we provided those key questions. Leverage those questions and the dialogue to make sure that as questions are asked, you can also provide some solutions through the models that have been marked. Next slide. And then just to thank you and say that there is a sustainability microsite. I've included it there with guidance and tools that are being posted as they are developed. So please access any type of information you might need, and don't hesitate to contact us if you need further information or guidance. Thank you.
Thank you so much, Iris, for this great overview on the sustainability planning. and the sustainability roadmaps. From these two global presentations, we now move straight into country experiences and examples. And we start with Brazil, and Yvonne de Paula, who is with the state government of Sao Paulo in the Training and Reference Center for HIV in the prevention management, and will provide us experience from Brazil in terms of scaled population programming. Over to you.
Olá, me ouvem bem?
Perfeitamente. We can hear you.
Então, sou Ivone e trabalho aqui no Centro de Referência Treinamento de UNAIDS, aqui de São Paulo, e vou falar um pouquinho para vocês sobre a experiência do Brasil, né, mais especificamente do estado de São Paulo, né, que é onde nós estamos. Começando para falar que a gente segue como referência a mandala de prevenção, né, com todas as estratégias implantadas nos vários serviços. Pode passar, por favor. A partir da mandala, vocês conseguem passar a apresentação? Eu não estou vendo ela passar aqui.
Next slide, please.
Isso, muito obrigada. Então, a mandala ela vai mostrando todas essas possibilidades de prevenção implantadas nos serviços dos municípios, com todas essas estratégias à disposição, pensando bem e também orientando e capacitando profissionais de saúde para a questão da zero discriminação. Pode passar, por favor? Seguindo, nós temos uma forma de organizar os serviços dentro de todo o estado que a gente chama de etapas do modelo do contínuo. Se vocês puderem passar, as pessoas vão poder visualizar essa etapa, que é a gente trabalhar isso desde a etapa de promoção, onde a gente trabalha as questões de prevenção com jovens que ainda nem iniciaram a vida sexual, trabalhando assim, né, levando as informações para esses jovens de uma forma tranquila, de uma forma segura, para que eles possam iniciar a vida sexual com naturalidade. E aí passamos por todas essas etapas: promoção, prevenção, diagnóstico, a vinculação, depois que a pessoa tem um resultado de HIV positivo, a importância da vinculação para que ela acesse o serviço de saúde, tratamento, retenção, né? Adesão a esse tratamento e, no final, né, desse cuidado do contínuo, a cura, no caso de sífilis e hepatites, e a supressão viral, no caso do HIV. Pode passar, por favor. Contextualizando aqui, nós temos o quê? O estado de São Paulo ele tem 645 municípios. Desses, alguns municípios, 165, são municípios prioritários para as ações de ST/AIDS por seus dados epidemiológicos, pelos dados aí de HIV e AIDS. Dentro de todo o estado, nós temos 210 serviços de atendimento especializados em atenção às pessoas vivendo com HIV/AIDS e 46 serviços, né, com ambulatórios para atendimento da população de travestis e transexuais. Esses serviços atendem regionalmente, né? Nem todos os municípios têm, mas todos os municípios têm um ambulatório de referência. E a gente temos a nossa epidemia focada, né, mais concentrada em jovens do sexo masculino entre 15 e 24 anos, mas chegando também com dados importantes até os 29 anos, e uma taxa de detecção de casos bem maior entre pessoas pretas e pardas. Então, essa amostra para nós desse contexto. Pode passar, por favor? Bom, seguindo aqui, nós temos, então, a estratégia de prevenção que nós chamamos de partil PREV-PERIFA. né, que são estratégias de prevenção para jovens moradores das periferias. E por que essa apresentação? Porque nós observamos ao longo do tempo, né, com as nossas pesquisas, que embora tenhamos políticas importantes de prevenção, os jovens negros, moradores das periferias, não acessam essas políticas. Então, o Partiu Prev-Perifa, nós vamos até o município, os profissionais de saúde vão até os municípios veem onde é que essa população se concentra, em festas, em bares, e aí a gente promove lá a ação de prevenção, que a gente leva PEP, PrEP, faz a testagem, autoteste, informação de qualidade para esses jovens, tudo ali, no convívio deles, onde eles estão, e a gente consegue, com isso, levar as políticas de prevenção para esses jovens que normalmente não acessariam os serviços de saúde, até por conta, né, de suas vulnerabilidades. Esse trabalho, ele tem parcerias importantes, né, para executar esse trabalho, parceria com ONGs, né, com organizações da sociedade civil, com parcerias com escolas, parcerias com outras instituições, para que esse trabalho seja de abrangência e a gente consiga levar a prevenção para lugares bem importantes, onde a prevenção não chega. Pode passar, por favor. A próxima estratégia é o Juntos na Prevenção, né? O Juntos na Prevenção, ele é uma estratégia junto saúde e educação, né? Entre esses trabalhos conjuntos entre a Secretaria de Educação e a Secretaria da Saúde. Não como uma ação pontual, vai lá, faz uma palestra, mas como um processo todo, onde as unidades de saúde locais, né, o serviço de atenção primária, mais as escolas, trabalham num processo conjunto de formação dos profissionais que trabalham nas escolas, dos professores, de toda a rede dentro da escola, e inclusive para os alunos do Grêmio, né, que são alunos que ficam na escola, eles são capacitados, eles passam, né, de um ano para o outro, as informações que recebem de uma forma entre pares, né, para os seus companheiros, com uma linguagem mais jovem, com uma linguagem mais atual, e a gente tem com isso a possibilidade de levar a prevenção para dentro das escolas, né? Esse trabalho, ele consiste numa fase que é feita dentro da escola, levando com a capacitação, com os preservativos, né, com todos os insumos aí de prevenção, e também um braço que vai para a comunidade, né, onde estão os pais, os tios, né, onde tem o moço do cachorro-quente, que vende cachorro-quente, aonde tem a lojinha que vende celular, e esses espaços na comunidade são frequentados pelos jovens. Então, a gente faz, né, nesses locais, estações de prevenção, que a gente fala. E essas estações de prevenção tem lá folhetos informativos, tem os preservativos, para que esses jovens possam acessá-lo independente de horário, né? Porque os serviços de saúde têm os horários delimitados. E esses jovens, eles têm um espaço dentro da comunidade maior, né? Tá à noite, o moço do cachorro-quente fica na praça e lá ele tem os preservativos, ele tem a informação para esses jovens. Essa é uma estratégia bastante importante no sentido de chegar, né, até esses jovens com o insumo, com as informações. Pode passar, por favor. Pensando na nossa epidemia, que atinge principalmente jovens, homossexuais, né, a gente tem uma parceria bastante importante com os organizadores das paradas LGBT, né, aqui do Estado. Nós temos no Estado todo 58 paradas organizadas ao longo do ano. E nesses momentos em que a população LGBTQIA+, vai para as ruas, vai para as avenidas, a gente tem a oportunidade de um trabalho conjunto antes da parada, durante o momento da parada e no pós-parada. Isso faz com que a gente consiga capilarizar, né, a informação, distribuição de preservativos, de autoteste e de informações. E a gente tem, durante o período da parada, um telefone de WhatsApp que funciona, né, quase 24 horas, para que se algum evento, se alguma situação de risco ocorrer com alguns desses jovens, eles possam acessar esse WhatsApp, que eu vou mostrar o número ali mais para frente, e adquirir as informações que necessitarem, né? De PEP, de locais onde faz, onde eles estão, aí eu explico melhor para frente. Nós temos aqui no estado uma campanha que ela anual de testagem, né, para as populações e que atinge 100% dos municípios do estado. Numa mesma época, os 100%, 645 municípios participam e eles realizam testagens, né, nos seus locais de maior prioridade, com o objetivo, né, de testar o maior número de pessoas possíveis, mas também de testar população-chave, populações prioritárias para essa atividade. Desenvolvemos parcerias com a Secretaria da Educação, da Justiça, né, e com universidades, potencializando aí o trabalho de prevenção. Pode passar, por favor? E aí a gente também tem um trabalho importante de extensão de ensino, onde aqui na nossa unidade nós recebemos profissionais de outras universidades, sabe, residentes, que é uma forma de levarmos essas questões, né, de prevenção, de levarmos essa questão importante de trabalho com relação a zero discriminação, de racismo, a gente levar para dentro das universidades. E temos uma linha de financiamento com a sociedade civil, né? A gente tem uma linha de financiamento para que ONGs, né, para que organizações não governamentais possam ter subsídios para projetos de prevenção para as várias populações chaves aí. Pode passar, por favor. Quando a gente tem dificuldade num determinado tema, né, a gente forma grupos com pessoas com essa expertise para que a gente possa adquirir esses conhecimentos, para que a gente possa passar esses conhecimentos, né, para os profissionais de saúde. É o caso que está acontecendo agora. A gente tem um grupo de trabalho que está estudando as questões sobre quimsex, né, sobre sexo químico, que é algo que está avançando bastante, que é algo que está chegando, né, até os nossos jovens. Então, já desenvolvemos um material, né, que eu estou mostrando aí à frente do material, para que profissionais de saúde sejam capacitados para ficarem mais antenados, né, para procurarem conhecerem melhor as pessoas que vêm aos serviços e se precisam de informações sobre o manejo, sobre essas questões, sobre o sexo químico, que é algo que nos preocupa bastante, porque nessas questões existem drogas que são utilizadas injetáveis, né? E para a gente que trabalha com as questões de HIV, com questões de transmissão da epidemia, isso é muito importante, que a gente possa capacitar esses profissionais de tudo. Atenção básica, os serviços de saúde mental, todos esses serviços. Pode passar, por favor, que eu estou terminando. E a gente temos, então...
You will have to conclude soon.
Não entendo, pode Tá bom, então podemos concluir aqui, porque acho que o principal já foi feito. Temos na tela aí o curso de integral para a saúde LGBT, formando todos os profissionais do Estado, né? Todos os profissionais do Estado, da saúde, da educação, que é uma forma, então, da gente melhorar o atendimento, da gente melhorar a postura de profissionais no atendimento dessa população prioritária para nós em termos de prevenção. Acho que eu posso parar por aqui. Agradeço a oportunidade, muito obrigada e espero que tenha contribuído aqui com um pouquinho da nossa experiência.
Thank you so much, Imone. That was a fantastic presentation on the rich experience in Brazil in terms of key population programming for different populations, including young key populations. From Brazil, we'll move to Nigeria now. Michael Akanji is a senior key populations advisor with the Heartlands Alliance in Nigeria. and they will be sharing with us the experience on achieving sustainability and scale in the program in Nigeria. Over to you, Michael.
Thank you very much, Clement. Good day to all. Next slide, please. Yeah. Yes, for us in Nigeria, it's also best to also look at what we have been doing so far. And when January came, what has been the realignment trends and some other models that we've been able to be putting in place that it's very sustainable. Next slide, please. Yeah. Next slide. Yeah, for us, one of those notable progress that we've made, it's the expansion of our DSD model, that is the differentiated service delivery model, where you have the community-based ART delivery, multi-month dispensing of ARVs, peer-led, that is the KP themselves are the one leading the testing and linkages to services, mobile and outreach clinics, where you go to where the KPs are, whether the hotspots or in difficult to reach areas. Also, we've also been able to strengthen our community-led and KP-led interventions, because these interventions are actually critical in the roles in terms of our demand creation and also our service deliveries. And in some locations, you've also have drop-in centers and safe spaces that allow KPs to be able to come and receive services. Legal aid is very, very important, because you can't talk about HIV interventions without talking about the other, key challenges that comes with HIV intervention for key population, most especially, as you know, that we are living in a very restrictive policy environment. So legal aid is equally very important. Mental health services at the community level, it's equally very important. It's something that we've strengthened, and harm reduction services. And for us in Nigeria, we've also have a multi-sectoral coordination mechanism like the technical working group, which actually supports in joint planning and resource mobilization. And KPs themselves are equally inclusive there. We have the national KP guidelines, which was first developed in 2016 and later revised in 2020. We've had our national KP size estimation and also the report of the mapping. They are also at the state level, because Nigeria, we have the national and also the state level. At the state level in Nigeria, we have what we call the state KP implementation plans, and also the inclusion of KP in the national strategic framework for HIV. We've also been able to develop, leveraging on the WHO consolidated guideline. Nigeria has also developed the consolidated service delivery guideline for HIV and STIs for KPs. And we also have one-stop shops. This one-stop shop is a KP-specific clinic that provides all services, including STI, HIV, cervical cancer screening, TB, and all those. Also, it makes the KP to be able to access services in a place that is non-discriminatory for them. Integration of mental health and human rights services have also been some of those notable progress we've been able to do for us. We've been able to scale up our PrEP services, both oral and injectable, including self-testing, that's HIV self-testing, and not just only providing legal aid. Inclusion in part of our human rights services that we've also been able to do is the integration of human rights and legal literacy in HIV programming. Next slide, please. Next slide. Then January came. So there is that transition from donor to the to increase government leadership in HIV programming. And this is actually to enhance sustainability. But while we are doing this, yes, just like we rightly said, there's need to have a strong policy safeguard to avoid diluting the effectiveness of these specialized services that we've been providing for KPs. There's also that emphasis on integration and efficiency, where key population services is being integrated into general public health systems. And this integration have also streamlined the intervention points, whether it's for reproductive health services, whether it's for TB services, and it's actually emphasizing cost efficiency. And this has also improved access and reduced stigma that does not compromise the safe and confidentiality of the environment. Next slide. Yet also, we've also been able to start focusing on high impact and cost-effective programming. And this is basically like focusing on high burden locations and deprioritizing lower prevalence regions. So the impact of this might also be that vital community-led human rights intervention like legal aid, mental health, can face exclusion because now we are reprioritizing and we are realigning. Then the issue of vertical KP-specific programs is being replaced with broader programs. And the impact of this is that the visibility of KP in national data can actually decline. It might even undermine targeted responses and accountability. Next slide. So another part of the realignment is shifting from digital and remote, shifting to digital and remote service delivery. So we started using some digital tools like online outreaches, virtual peer support, self-testing, and telemedicine. This is very important because it's cost efficient. But while we are doing this, it's also very important that we include digital literacy in this, privacy safeguard, and also attention also needs to be given to excluded groups within the KPs themselves. That is persons with disabilities who are also KPs too. It's very important that we also pay attention to this group as we are shifting to digital and remote service delivery. Then another aspect of the realignment that we are beginning to see is that the KP organizations themselves and the KP network, they face cuts in funding in terms of operational costs, staff salaries, and capacity building. So this also provide a kind of implication of the pressure to deliver more, but with fewer resources. And in some cases, we are also beginning to also see the linkage with mental health and also the funding cuts too. That those are some of those trends that we've been able to see here. But despite all this, next slide. But despite all this, there have been a lot of models that have been scalable and that is promising in Nigeria. For example, the health insurance model, where we now have inclusive health insurance. Like I said, the one-stop shops that we have, some of them has also been embedded into the community health insurance scheme, where KPs that access services can also be beneficiaries of the health insurance. And some of the slides, some of these OSS, actually, that is the one-stop shop, also are beneficiaries of what we call equity funds from the government. So this is part of something that actually contributes to long-term financial protection and access continuity for key populations. Then I've spoken about the issues around mobile outreach and decentralized service delivery, where the KPs themselves have been able to also collaborate with the healthcare facilities to go to the communities and engage in service delivery. And some of this service delivery also include harm reduction kits, that is needle and syringe programs that we've also been able to do. And this is cost efficient, is adaptable across any geographical settings. Next slide. So I've talked about the issue of community itself. Then another part that is also scalable from Nigeria is also the issue of tax shifting, where lay workers, community peer educators, peer navigators, and health extension workers join together to provide selected HIV services. And this is as a result of lay workers that are trained, and the community health extension workers and the facility staff continue to provide that mentoring for them. This has helped in reducing the constraint in terms of the health system, and at the same time, it also built community ownership. And that cultural competency, because of the diversity of the country, is also there. And it also helps to also bridge the gap in terms of workforce shortages, most especially for healthcare providers. Then the use of digital and health innovations is also there. We use mobile app, SMS platforms, social media, telemedicine that provide HIV prevention messages, treatment literacy, adherence, appointment reminders, and also consultations too that can also be. Then part of it is also, and this actually is low cost and is being able to reach a larger audience, most especially young key population and hard to reach and closeted individuals who are not open about their sexuality, but they can access the services through the digital means and book an appointment at a specific time and on a specific day, and they receive their services. Next slide. Then there's that private and public partnership that is also coming up. In Nigeria, for example, there has been an increased number in local production of lubricants, and we've also seen local production of RTKs and also needles and syringe programs. Why this is very important, because health security is linked to commodity manufacturing. So it's very important that when we actually leverage on resource leveraging through this public and private partnership, it can also help in sustaining HIV interventions for key population. Then the issue around social protection and livelihood, because it's very important. You can't provide holistic HIV care for somebody without reducing their vulnerability. And in the reduction of vulnerability, we need to address the structural barriers. Part of those structural barriers is actually providing livelihood for them. And that integration of livelihood support and vocational training for key populations has actually increased their adherence and also create an incentive for them to also continue in care. Next slide. So finally, we can't really talk about scalable program without talking about political will, without talking about the issue around policy and also the funding for HIV programming. So it's very, very important that when we talk about sustainability and scalable program, that political will, policy, and also funding is very, very important. So while we are also talking about scaling HIV intervention strategies, key populations program must not be sacrificed. They must actually be included there, and also in terms of quality. The community itself is very important. Community leadership, it's essential because it will be able to continue the programming and also provide responsiveness and resilience for key populations program in Nigeria. Thank you very much for this. Over from me.
Thank you so much, Michael, for this great overview on the Nigerian experience. We'll now move to another region again, to Moldova. And Svetlana Plamadyala is the country director of UNAIDS Moldova and will share with us the Moldovan experience in terms of sustainable and scalable primary prevention for key populations. Over to you, Svetlana.
Thank you, Clemens. Hi, and hi, colleagues. It's a real pleasure to join you today and share Moldova's experience in building sustainable and scalable HIV prevention programs for key populations. Next slide, please. So just some small facts about Moldova, which is a small country of 2.4 million population, located between Ukraine and Romania at the crossroads of structural inequalities and humanitarian pressures. Moldova has the third highest HIV burden in the WHO European region after Russia and Ukraine. The epidemic is concentrated in key populations. That is why they are our first priority in our national program. And the fastest growing trend is among the men who have sex with men. One area of concern is Transnistrian region. It's our breakaway region with limited national control and strong Russian influence. This region holds 1/3 of our national HIV burden. So there are 5 rayons, like the administrative units, versus 33. So in 5 rayons, 1/3 of our national HIV burden. Yet programs here are more fragile and harder to implement than just a few years ago. And it's a lot about the Russian influence, yeah? So I was thinking about sustainability and having Transnistrian region and challenges there shows us that sustainability isn't only about funding or systems. It is also about, and it is shaped by politics and geopolitics, which can either enable or dismantle the progress. And these factors, I mean politics and geopolitics, are felt since 2025, I think, by almost all the countries in the world. And it's not only about US cuts, but it's also about the prioritization by countries, yes, and putting accent more on security, and somehow development comes after it. Next, please. So over the last decades, Moldova has built, I think, a resilient HIV prevention system, which is anchored in harm reduction and rights-based approaches. We scaled, for example, the opioid agonist therapy to all prisons in Moldova, which is a best practice also recognized by my organization, by UNAIDS. And harm reduction, for example, in prisons are delivered through peer-to-peer approaches. So not medical staff delivering the service, but peer-to-peers. And it's a model in Moldova since 2000. So in the civil sector, we have about 20 NGOs that are providing community-led prevention. So all the services from the comprehensive package, rapid testing, and those are supported by national standards on HIV prevention, staff capacitation, and service accreditation. In 2018, you can see on the slide one of the milestones that we achieved. It's that HIV prevention services fully started to be financed through the National Health Insurance Fund. It has a prophylaxis fund within the health insurance, which is 2% actually out of the total budget of the National Health Insurance. So to ensure that we have access to those resources, it took us 2 years of preparation, and it meant a lot of advocacy based on evidence and based on models of service delivery and of scenarios on what can work efficiently. It was also about building the NGOs' capacities to work with public finances, as where they were mostly used to work with global fund resources. But it was also about capacitating the National Health Insurance Fund, because they had they are working only with health institutions and not with NGOs. It was also about developing a procurement mechanism of these services from the National Health Insurance. So my message on sustainability here is that it was achieved through institutionalization, integrating services into the national protocols, standards, budgets, and systems, so that they do not rely only on external aid. So in terms of several innovations that we developed since years are the mobile clinics, the community PrEP, self-testing in pharmacies, which also means the relationship and partnership with private sector, vending machines, which means also involvement of local public authorities. So to ensure that we have vending machines in public spaces that are friendly to our key populations. Next, please. For PrEP, I wanted just a few thoughts. Initially, we delivered it in 2018 through medical institutions, and we reached in a year only 2 clients in the whole year, But when we switched to community-led model in 2019, so the uptake started increasing, and the success was because of the PrEP, which became accessible, friendly, with trust-building medical referrals and on-site support. So the PrEP success, as you see by 2024, shows that sustainability also means designing models that people trust and use, especially for key populations who face very high systemic stigma in our country. So we measured stigma through a UN score, Social Cohesion and Reconciliation Index, and it seems that, for example, sex workers, LGBTQI community, people who use drugs, face a 88% stigma from general population, which is higher than some other vulnerable groups. It's really a very, very high stigma in these groups. Next, please. So our focus has been on putting people at the center. Moldova's approach is based on choice, convenience, and trust. We combine community leadership, peer outreach, digital tools, and real-time monitoring through community-led mechanisms. We offer also, besides the main service package, some attractive services, also results-based incentives, for example, for peer workers, but also for the health staff, and a growing role for the digital community-led monitoring. So these are not just interventions, but also part of a shift toward accountability and people-centeredness. Next, please. So we also faced the refugee and humanitarian crisis since the beginning of the war, and it also included the work with refugees from key populations from Ukraine. So we adapted our response to include refugees, NGOs jointly with the health institutions, integrated HIV, TB, hepatitis, but also opioid agonist therapy, mental health services into the humanitarian programs, working through Blue Dots, accommodation centers, web outreach. So refugees received the same level of care as host communities. And this was not only happening in HIV response towards this crisis, but it was a government-led narrative. Yeah. So importantly was here that NGOs were already accredited to deliver key services, so it was easy to scale up fast. Refugees in time became also part of the workforce, like working as health professionals, social workers, and community responders. And it means also this, that we try to integrate refugees as much as possible in our society. So sustainability in this case means being also crisis ready, with flexible systems that include, not just serve, but include refugees, reinforcing both equity and resilience. Next, please. So this is about HIV prevention coverage from domestic funding, and you can see in the first diagram that prevention is not only the first priority in our national program, but it also accounts for 34% of Moldovans' total HIV expenditure in 2024, which for us means a strong signal of political and financial commitment. On the second diagram, you can see the scale up of the investments in US dollars here. Okay, not in our national. Yeah. So you can see how it increased over the years. Yeah, the investments from National Health Insurance Company. They were supported by evidence, by modeling, by investment cases that we have, and we use those messages to advocate for domestic funds, which helped us, the evidence mostly showing that prevention saves lives and cuts long-term costs. So the model itself relies on several pillars, I would say. A strong policy framework, which is our national AIDS program, as I said, having the first priority, as first priority, the HIV prevention in key populations. It's also the procurement mechanism in place with the National Health Insurance Company and capacities of the NGOs, but also public institutions to both disburse and absorb resources and transform actually the investments into reduced new HIV transmissions. It's always about an ongoing dialogue among all key stakeholders to be able to improve the model. and of course, reliable data. So this is really a power for advocacy, for the design, but also for the correction of what we do for people. We are currently discussing with the National Health Insurance Company about multi-year funding and also results-based financing to ensure greater predictability and efficiency of the programs. So next, please, and this is about the concluding. Yeah. So I think in Moldova, we think to have sustainable and scalable HIV prevention is not only possible, it's happening. And again, several factors that really were of help to build this is relied on evidence and data, on the political will, and also adding here geopolitical factors, normative systems, meaning standards, meaning mechanisms, meaning the national program policies in place, yeah, pre-existing infrastructure that made scale up feasible, and also partnerships that ensured responsiveness and accountability. So it's not a destination. If we speak about sustainability, it's also a mindset, and it means building systems that are responsive, rights-based, and also ready for the long haul. I'd like to thank you for this opportunity to share Moldova journey and yeah, to be part of this remarkable community of practice. Thank you.
Thank you so much, Svetlana, for sharing this, special experience in Moldova with, strong national ownership of key population response. We now move into a community perspective, and Roberto Paulo from Lambda Mozambique is the executive director, an organization working with sexual minorities, will actually provide a perspective. Roberto Paulo, over to you.
Bom, boa tarde, bom dia ou boa noite, depende da hora que nos ouvem. Muito obrigado por esta oportunidade. Como disse o nosso facilitador, meu nome é Roberto Paulo, falo-vos de Moçambique. Bom, em termos de estrutura da nossa apresentação, vamos fazer uma breve apresentação da Lambda, falar um pouco do contexto de Moçambique, barreiras que afetam o acesso aos serviços de HIV, preocupações da nossa comunidade com a programação atual da resposta ao HIV. Deixaremos algumas recomendações e aquilo que chamamos de chamada para a ação. Bom, em termos de breve apresentação, a Lambda é a Associação Moçambicana para a Defesa das Minorias Sexuais. É uma organização que existe desde 2006. A nossa visão é uma sociedade onde os direitos humanos das pessoas LGBT são respeitados, garantidos por lei e assegurados pelo Estado. E a nossa missão é liderar o movimento LGBT e mobilizar a sociedade, tornando-a mais favorável à promoção e garantia dos direitos econômicos, políticos e sociais das pessoas LGBT. Bom, não consigo ver a apresentação na tela. Não sei se há algum problema ou técnico. Hello? Hello?
Question to the SSLN team. Do we have the slides?
Thank you, Clemens. We're having some technical issue here. Maybe he may want to share directly, please.
Okay, thank you. Roberto Paulo, could you share directly the slides? That is possible.
Well, it's not giving me. Okay, I think that now I can do it. Okay, desktop. Oh, Frank, esta coisa aqui não está a funcionar. Yeah. Oh. Yeah. Não, já está. Está no desktop isso. Yeah.
If he's still struggling, I think we can share.
Okay, please. I appreciate. No, it's on the course. It's on the Okay.
Okay, thank you.
Oh.
Um,
Muito obrigado. Próximo slide. Bom, em termos de contexto de Moçambique, a nossa prevalência do HIV está estimada em 12,5% entre adultos dos 15 aos 49 anos de idade, e aqui nós temos cerca de 2,4 milhões de pessoas vivendo com HIV. Moçambique estabelece, considera a população-chave, considerando aquilo que é a denominação da OMS, portanto, são 5 grupos: homens têm sexo com homens, mulheres trabalhadoras de sexo, pessoas que injetam drogas, população transgênero e prisioneiros. Moçambique, contrariamente a alguns países africanos, despenalizou relações homoafetivas em 2015, portanto, é considerado dos países que não criminaliza a homossexualidade. O Plano Estratégico Nacional da Resposta ao HIV, que está em execução neste momento, ele estabelece como um dos princípios a não discriminação com base na orientação sexual e identidade de género, o que mostra, de alguma forma, um grande progresso naquilo que é o respeito pelos direitos LGBT. A população-chave está representada no mecanismo de coordenação do país para o Fundo Global, ocupando 2 assentos para o nível do MCP. O trabalho de sexo em Moçambique não é, à luz da lei, não é considerado crime, pois embora não tenhamos a regulamentação, mas não é criminalizado. Em 2016, em Moçambique, nós aprovamos uma diretriz para atendimento às populações-chave. Esta diretriz tem a vantagem de assegurar que o Ministério da Saúde ofereça serviços amigáveis para as populações-chave. Em janeiro deste ano, portanto, as ordens executivas do governo americano impactaram negativamente nos programas para a população-chave e promoção de direitos LGBT, o que promoveu de alguma forma um retrocesso abismal. Nós vínhamos, apesar destes progressos que eu fiz menção, quando saíram as ordens executivas, muitas das atividades que eram realizadas não somos mais permitidos realizar na mesma dimensão, portanto, isto é um retrocesso muito alto. Nós temos em Moçambique uma lei, que é a Lei 3/97. Esta lei, ela de alguma forma criminaliza as pessoas que usam drogas. Então, tem sido um grande desafio quando, por um lado, nós sabemos que precisamos de desenvolver programas que visam a redução de danos. Então, a existência desta lei tem sido um grande desafio para parte da população-chave, que são as pessoas que usam drogas. Infelizmente, apesar de Moçambique ter despenalizado a homossexualidade, muitas das organizações de população-chave e da comunidade LGBT, infelizmente, não conseguem obter um registro oficial das autoridades moçambicanas. O slide a seguir. Bom, apesar do Plano Estratégico Nacional da Resposta ao HIV, bem como a diretriz de atendimento às populações-chave, que são instrumentos aprovados pelo governo de Moçambique, serem bastante progressistas, permitirem que serviços sejam oferecidos às populações-chave e à comunidade LGBT sem estigma e nem discriminação. Infelizmente, o que nós temos assistido na realidade é que continua a haver situações de exclusão na oferta de serviços. Continuamos a ter profissionais de saúde que, no lugar de oferecer serviços de saúde, ainda continuam a oferecer julgamentos, continuam a discriminar, que é um grande desafio. Boa parte dos servidores públicos continuam a oferecer tratamento desigual e julgativo, o que desencoraja a procura dos serviços. Nós temos, ao longo dos últimos 10 anos, temos vindo a fazer capacitações para profissionais da área de saúde, para ver se eles oferecem atendimento amigável, para ver se eles respeitam os direitos humanos, mas infelizmente continuamos com um número muito elevado de profissionais que ainda discriminam, oferecem tratamento desigual, e a desvantagem disto é que, a partir da altura que nós somos discriminados ao procurar um serviço de saúde, nós temos os nossos pares, nós comunicamos, obviamente que isso vai desencorajar a procura de serviços de saúde. O fraco nível de escolaridade e deficiente acesso ao emprego formal aumentam o nível de vulnerabilidade das populações-chave face ao HIV. Infelizmente, em Moçambique, boa parte das pessoas que fazem parte das populações-chave tem um nível de escolaridade baixo, e isso faz com que, por ter um nível de escolaridade baixo, faz com que não sejam apetecíveis, ou seja, não conseguem ter oportunidades de acesso a um emprego formal, e a consequência disto é que esta pessoa que não tem um emprego formal, de alguma forma deve sobreviver, e isto torna esta pessoa vulnerável, por exemplo, à prática do sexo transacional, onde o poder de negociação desse sexo transacional é baixo para a pessoa que é da população-chave, e por conta disso torna vulnerável à infecção pelo HIV. Os programas de redução de danos, infelizmente, são constantemente secundarizados ou enfrentam barreiras para ter aceitação das autoridades. Das vezes que nós, como país, introduzimos programas de redução de danos para pessoas que ingeram drogas, foi um grande desafio, porque as autoridades locais, muitas delas, não olham de boa forma os programas de redução de danos. Tem sido muito difícil convencer as autoridades locais a aceitarem estes programas, o que tem sido um grande desafio em termos de ações de advocacia para assegurar que estes programas de redução de danos sejam implementados. A recente política relativa à DEIA, isto no âmbito das ordens executivas, tem estado a limitar a oferta de serviços para a comunidade LGBT e a aumentar os discursos de ódio e a elevar os movimentos anti-direitos LGBT. Então, o que nós temos estado a ver desde que foram emitidas as ordens executivas, esta questão do DEIA, que é, portanto, intervenções voltadas para diversidade, equidade, inclusão, acessibilidade, que são de alguma forma desencorajadas pelo governo americano, têm estado de alguma forma a reduzir a oferta de serviços para a comunidade LGBTQIA+, e de alguma forma isto estimula discursos de ódio. Estamos a sentir cada vez mais o aumento de vozes que tentam exacerbar aquilo que são os discursos de ódio, discursos contra, portanto, a promoção dos direitos humanos das pessoas LGBT. Slide a seguir. Bom, nós temos algumas preocupações quando olhamos para aquilo que é a
We'll have
programação.
to, yeah, maybe if you could conclude within a minute or two, because we've run out of time.
Bom, nós estamos preocupados com a extrema dependência da ajuda externa para a resposta ao HIV no nosso país, sobretudo. 97% dos recursos para a resposta nacional ao HIV, ela é através de doações. E isto nos preocupa porque qualquer mudança externa nos países que financiam a resposta ao HIV no nosso país, isto tem um impacto tremendo naquilo que são as políticas nacionais. Nós vimos recentemente, a partir das ordens executivas, muitos dos programas que nós temos foram terminados, as intervenções ficaram canceladas, e isto chama a nossa atenção no sentido de precisamos, se calhar, fazer advocacia para que o nosso governo aumente aquilo que é a disponibilidade de recursos para a resposta ao HIV. Precisamos, de alguma forma, fazer esforço para aumentar o nível de profissionais de saúde treinados para oferecer atendimento amigável, sem julgar com base na orientação sexual e identidade de género. Temos um problema que tem a ver com dados e, infelizmente, há alguma redução naquilo que é a preocupação em trazer dados desagregados que mostram os diferentes subgrupos de população-chave, sobretudo quando falamos da população LGBTQIA+. Não vemos muitos dados ligados à população transgênero e isto, de alguma forma, aumenta a invisibilização destes grupos, o que achamos que é extremamente importante que seja realizado. O slide a seguir, por favor. Bom, em termos de recomendações, nós sentimos que é preciso que haja um aumento do envolvimento da comunidade no desenho e implementação dos programas da resposta ao HIV. É preciso que sejamos envolvidos a partir da altura que os programas são concebidos e são implementados. Sentimos que é importante que se faça uma integração do módulo de educação ligada à orientação sexual e identidade de género nas formações oferecidas aos profissionais de saúde, como forma de assegurar que todos os profissionais de saúde sejam treinados para não discriminar as pessoas com base na sua orientação sexual e identidade de género. É preciso assegurar que os modelos diferenciados permitam a dispensa de medicamentos para PrEP e o próprio TARV ao nível comunitário. Nós temos os centros comunitários que são espaços onde é possível fazer a oferta de PrEP e TARV, então é importante que a resposta considere essa dispensa de medicamentos ao nível comunitário. E precisamos assegurar também a disponibilidade de insumos de prevenção. Nós, infelizmente, experimentamos várias situações de ruptura de estoque, sobretudo de lubrificantes. Então, é importante que, ao nível do serviço público de saúde, os lubrificantes estejam disponíveis. E precisamos também estabelecer um mecanismo de seguimento, porque, ao nível comunitário, nós temos os números de identificação únicos dos nossos beneficiários, mas quando referimos aos serviços clínicos, são atribuídos números de identificação do doente, que é o UNAIDS, e estas duas formas de identificação, elas não se encontram. Precisamos encontrar uma forma em que é possível seguir o paciente a partir do nível comunitário até ao nível clínico. E mais uma vez a questão do financiamento, precisamos assegurar que o Orçamento Geral do Estado aumente aquilo que é a fasquia que vai para o setor de saúde e HIV, e também mobilizarmos o setor privado para que dê a sua contribuição. O último slide, por favor. O último slide. Então, no último slide, nós recomendamos que é importante que haja descriminalização das pessoas LGBT, porque é importante assegurar que a resposta ao HIV seja abrangente para todos. Precisamos assegurar que organizações LGBT sejam registradas, porque só assim elas poderão dar o seu contributo na resposta ao HIV. E precisamos conceber modelos de resposta muito mais inclusivas e menos heteronormativas, como forma de assegurar que haja, portanto, envolvimento de todas as comunidades na resposta ao HIV. E, por fim, precisamos assegurar que todas as abordagens ao HIV, elas respeitem a questão dos direitos humanos, se quisermos assegurar que haja menos infecções e, de alguma forma, controlemos a epidemia do HIV. E muito obrigado.
Thank you so much, Roberto Paulo, for these important principles, which bring us to the end of this webinar. The Q&A has actually happened in the forum, in the chat, and in the Q&A itself. So I guess we do not have time to go back to that, but we encourage you to continue exchanging. What we've heard today is really different perspectives and different models. There's no one-size-fits-all solution, but still we have heard from Roberto Paulo at the end, but from all speakers essentially, that there are some important principles that are required in key population responses. We need scale that really enables us to reach key populations, not just in one site or venue, but really nationally wherever key populations are. We need equity in access, and that requires also community leadership in addition to the scale. Whether we have integrated models, more co-located models, or dedicated elements like outreach, they all need to be trusted and ensure stigma-free and non-judgmental service delivery. And even in the most integrated models, this will require purposeful design and a national program beyond the project or beyond specific activities. Key population responses in the context of HIV prevention need purposeful design and a national program and financing model with health financing elements, but also non-health and community financing elements in the different formats that we have seen. As we have mentioned in the chat, a document will come out summarizing much of the evidence and the models in countries, and an updated guidance piece as well, which can be used among other purposes for the design of national programs and global fund applications. With that, we end here, and I'll just like to end with big thanks to all our presenters, to our interpreters, to the wonderful SSLN team, Parinita Carabo, Madonna Lequetze, Tony Carey, and whoever I may have forgotten. Thank you so much. And thanks to all the participants. And it's ultimately you who make this community of practice alive, and the practice always comes at the end or after the webinar, and we're committed to and look forward to continue working with you on building sustainable and scaled key population responses within the overall HIV response. And with that, we look forward to connecting with you again, and wish you a wonderful rest of the day or evening wherever you are. Thank you.